Good afternoon, good afternoon, good afternoon. This is Zed 101.9 FM, and you are very welcome to the Zed Wellness Link. I'm your host, Dr. Padiaite. This month is Women's Month, and so our focus has been on problems that affect women. Last week, we spoke about uterine fibroids. Dr. McCarthy was here, and we delved into all the aspects of uterine fibroids, cause management, the things we can do about it, and how it impacts your life. It was quite a detailed presentation. Dr. McCarthy is quite the expert on uterine fibroids, and so if you didn't watch it, I'll encourage you to get the video and watch. In continuation of Women's Month, today we are talking about a problem that affects more women than most other diseases do. It's a very common problem, and unfortunately, those who have it don't always know that they have it. And so it's something that is really important. Its effect far exceeds what we know. The condition we are talking about today is called PCOS, and that happens to be my special area of interest. And to discuss the subject with us today is our dear friend Laurentia Massa Oteng. She's a clinical psychologist and somebody who also has to deal with PCOS. But because of that, she has researched the subject extensively. She asked me so many questions that I said, you know something, just come and ask me the questions in studio so that other people will get the answers that you are getting. So today, our program is going to be a little bit different. Laurentia is going to be asking the questions, and I'm going to be answering. I hope I can answer all her questions, because the amount of things she knows is dangerous. She may floor me. Laurentia, thank you for coming.
Thank you very much, Doc, for inviting me.
I'm really glad that you accepted our invitation. One of the things that fascinated me about you is how well you knew the subject and how much research you had done. And it was quite uncommon. Most of the time when I'm giving people treatment, I have to explain this and that and that. When I say something to you, you tell me, oh yes, I've done the research already, and I know that this and this, that. I'm like, hey, Charlie, this is my patient. She may flum you. I have one guy, he's an engineer, and he knows so much about one particular subject that he actually gives me information. It's not the other way around. I'll be there, and then you say me, have you seen this? My answer is usually no. Then we're going to discuss it in quite detail. So it's quite nice sometimes when you have clients who really understand the subject and they help you to treat them better. So, Laurentia, I'm at your service.
Okay.
How long have you known that you've had PCOS?
I've known that I've had PCOS for 3 years now.
For 3 years now.
So it's a condition I never knew I had until I started trying with fertility. Before, even 3 years along the line, I'm 6 years in marriage, 3 years along the line before they diagnosed me of PCOS.
Ooh, okay. How did they notice? How did it present in your case?
From the beginning, with the infertility issues, when I go, they do the regular scans and everything. Most of them would tell me that you are fine, just relax. But deep within me, I knew there was a problem.
Something wrong.
Because since senior high, I've always had irregular periods.
Aha.
And because I wasn't really sexually active, it didn't come as a bother, because if I'm missing 1 or 2 months,
the period I didn't want it to come.
I didn't even want to come because I have so much pain when it actually comes. So when I got married, 1 year along the line, I didn't even wait for 1 year and realized that no, I'm sure that there would be a problem. So let's seek medical help.
And the doctors were telling you there was no problem.
The doctors were telling me there was no issue. So along the line,
I apologize.
Just one doctor told me to run several hormonal tests, including a test he called AMH, anti-Mullerian hormone. And then he realized that it was far above the
normal,
number. And then he told me that physically, when he sees me, he sees that I also have symptoms of PCOS. I didn't have a cyst though, but the physical symptoms, the hair, the acne and everything, my weight and the irregular menses indicated that I have PCOS. So I found out 3 years into my marriage, and all that time I was just trying and there wasn't any baby.
Aha. So if you're sitting at home right now and you have, what did you say, irregular menses, acne, hair, and you are trying to get pregnant and the pregnancy is not coming, or even if you're not trying to get pregnant, if you have those things, you can suspect that you have PCOS.
PCOS, yes, please.
Good. So when you were doing all this, what were the things that you wanted to know that you somehow didn't get answers to?
Okay. So
Yeah, go ahead.
all right. So I wanted to know what exactly is PCOS,
Okay.
and how does it affect the body?
So the funny thing about PCOS is that unlike most people discover it as a fertility problem, it's actually not a fertility problem. It's a metabolic problem. And that is why I believe that men, if they had ovaries, will have PCOS. But I believe that the same problem that happens in women happens in men. We just don't have, men don't have periods. So therefore we can't detect it by the fact that you don't have periods. And if a man has extra hair, he just looks like a man. But technically, if you checked, the same basis occurs also in men. It's actually a metabolic problem. But the manifestation, which caused the definition of PCOS, which is polycystic ovarian syndrome, is that the woman tends to have an irregular menses and may or may not have excess hair or acne on her body, hair, face, back, acne, face, back, chest. And then when you do a scan, you discover that she's got several follicles, far in excess of the amount that we expect to see on her ovaries. So because there are multiple follicles on the ovary, which come like black circles, plenty, that is why the word polycystic came about as a multiple cysts. And because it comes with the hair and the irregular menses, that's why it became a syndrome, because it's more than just one particular condition that we see. So that's actually what the condition is, and that's what it stands for. So if you have any of these things, or more than, or two or three of these things, because you can actually have just two of the things we spoke about, either the periods being irregular with the hairiness, or the periods being irregular with no hairiness, but the ovaries look with the multiple cysts, or the ovary looks multiple cysts with the hairiness, but your periods are still coming. They are all still in the same family. Yes.
Okay. All right. And I also wanted to find out what tests are involved when you are trying to diagnose a person with PCOS. Because this is a problem that for the past 3 years, I didn't get any doctor to do particular hormonal tests to find out that I have a problem with PCOS. So if you are diagnosing a person with PCOS, what are the series of tests
that we look out for? For there are a couple of different tests. Let's start from, so assuming the woman does have a menses during the first 3 days, and that's really important. The timing of those tests are really important. There are a series of hormonal tests that we can do during the first 3 days of the menses. We can do it when you're not having your menses at all, but the interpretation is best when it is the first 3 days. Now we check your hormone profile. So the hormone that causes you to produce eggs, the hormone that causes you to ovulate, the estrogen hormone, the progesterone hormone, we check all those. Those ones will tell us if your ratios are proper. At the beginning of a cycle, one of them is supposed to be high and the other one is supposed to be low. If we check at the beginning of the cycle and the low one is high and the high one is low, which is we call an inverted ratio, we automatically suspect the fact that you may have PCOS. Then there are other things that we can check after that. We check your egg reserves. That's the AMH that you mentioned about. People with PCOS tend to have high AMH. And that is because the eggs that they should be released, the AMH measures how many baby eggs you have. The eggs, if you are releasing eggs every month, the AMH levels tend to be normal. If you don't release eggs every month, then from your age, you would have an excess amount of eggs hiding there. So when we test, each of those eggs is secreting the AMH, the anti-Mullerian hormone, and therefore it tells us that it is too high for your age. That means you're not releasing the eggs. That means the eggs, you are hoarding eggs. Calabula is not good. So your body then starts to manifest it in different ways. So the AMH test tells us that, suspects that, this woman may have PCOS. Of course, when we do the scan image, you see it straight away that there's a particular arrangement of the follicles. So when you see it, you know that this woman has got PCOS. You can test the testosterone levels, but I tend to recognize the fact that we do the testosterone, the person may have the appearance, but when you test the male hormone levels, they tend to be normal or low normal. So it hasn't been as beneficial in our population. Maybe in other populations, but in our population, it hasn't been as beneficial. The other test that we have, sex hormone binding globulin tends to be on the lower side. But what I have found it become very interesting is your insulin levels, not your sugar levels. but your insulin level. Whenever I tell people that we have to check your insulin level, so I check my sugar, it's normal. I didn't say sugar, I said insulin. Because the major cause, one of the major causes behind this is what we call insulin resistance. So they tend to have higher insulin levels than they should. And that is because the defect is from an insulin metabolism problem. And that is where the whole thing comes from. And the PCO is actually a manifestation of that metabolic problem. So these are the tests that you do, and to give you a fairly good idea. Sometimes you meet the person, the sugar levels are high, but most of the time sugar levels are normal, but the insulin is high. And that gives you an indication of the fact that this is the insulin-resistant type of PCOS. Those ones, you like them because you know that bring the insulin down, other things improve. The ones that the insulin is normal, you know that you have work to do because you don't have a hook to hang your treatment on, because that major one is it's off. But these are the tests that you do. Now the AMH can do it at any time. But the FSH, LH, estrogen ones are best done ideally first 3 days of your menses, maximum first 5 days, but ideally first 3 days. And when the results are abnormal, then you know for sure that this indeed is what the problem has. If you do the test on a different day, you can't interpret it in that manner. And so sometimes people come with a test and I say, on what day of the cycle did they do it? Then they tell you day 15 or day whatever. It becomes almost useless because you can't use it for the purpose which it was requested for.
Okay. So we need to do it at a particular time in the cycle.
Yeah. And you must also remember that if you've got irregular menses, your prolactin levels may also be abnormal. So it's not only the FSH-LH ratios that we are looking at, but some people also come in when we discover their problems actually from high prolactin levels, and the other hormones are normal. So an irregular menses or not having your period is not only PCOS. It could also be a prolactin problem or even a thyroid problem. So if you don't see one, you look for the other and the other and the other.
Okay. All right. Thank you, Doc, for that insightful information. I also wanted to find out that with PCOS, is it something that is genetic? I'm asking this because before I knew what PCOS was, and after I knew what I know now, looking at my mom, looking at my grandma, they have hair like myself, they have acne, but the problem is they gave birth around 21,
yes.
20.
No, so I told you that you are smart. That is the secret.
Why am I having the issue now? Because I tried later, or I just want to find out that is there a genetic predisposition to that?
There is a genetic predisposition, and the observation that you've made is brilliant. First of all, you inherit the defects from your parents, one or the other or both. So on one line of the family, you may notice a preponderance that they tend to have diabetes more often, or they tend to have the appearance, which is difficulty in losing weight, plump middle portions of their body, their hairiness, irregular cycles. You may also notice, or they may not have, the older people tend not to have fertility problems. And that is because they marry early and they start having children early. So I met a woman in Nkoko years ago when I was working there who has 3 children and has her menses 3 times a year, 3 or 4 times a year. That's it, the whole year. And she thinks she's normal. She has no idea that she has a problem. She's on a period in Saneba. But the funny thing about it is actually the fact that her problem, because she has started having children early and she's had them over intervals, she didn't ever feel that she had a fertility problem. Now, the problem tends to get worse with age. So the older you grow, the more your challenges appear. So your mother, your mother and your grandmother tended to start having their first periods later. Your grandmother may have had her first period at 17 or 18. Your mother may have had it at 14 or 15 or maybe 16. And maybe you have yours as 12. Now, those people tended to have their periods around 16. Then by latest 20, 21, maximum 22, they were married and they started having children. The symptoms are not as bad when you're younger, but as you grow older, it gets worse, because as you gain more weight, it gets worse. As your diet gets more westernized, it gets worse. So the earlier you try and have children, the better. But the older you are, then the more challenging it is. But to specifically address the question, the observation you made, yes, there is a genetic component. Now, if you have a certain kind of lifestyle, that genetic defect is not able to manifest itself as much, because the defect is somewhere in your glucose metabolism. If you don't give the body a lot of glucose, the defect doesn't manifest. If you give the body a lot of glucose, the defect will manifest, because your glucose load exceeds the ability of your body to handle, and then the problems arise. And their diet is different from your diet. So the way your grandmother eats is different from the way you eat. You eat more processed food. She ate less processed food. So even her diet alone reduces her predisposition, even though the effect may actually be just the same. So early marriage in different diets allows them to get away with it. But unfortunately, in our time, later marriage and more processed food and higher carbohydrates or easily more refined carbohydrates in our diet allows us to actually have a worse problem.
Okay, thank you very much for that. So do you recommend with that if a person naturally, as fertility declines with age, do you recommend that if a person is PCOS, naturally having difficulty with fertility, should start treatment early? Or
yes, you should start treatment early. You shouldn't wait till when you get married. No. The lifestyle changes that you can make start now. I tell clients this: if we intervene now, you will not be diabetic when you are 50. If we don't intervene now, by the time you are 50 or 60, you will be diabetic. And I'd rather prevent the cutting your leg discussion now, because the choices you make now can ensure that we will not cut your leg when you are 70, or by lifestyle changes that you make now. So that one, it's really important that even though you are not trying to have a child now, we should put certain changes in your lifestyle to reduce the effect of the disease so that you will not get those kinds of challenges early. It would also encourage you to have children early.
Okay. That's interesting. All right. So when you're talking about the fact that weight gain is one of the characteristics of a person with PCOS, what about the other people who don't have weight? Some people normally think, PCOS is you have weight, insulin resistance, but some people don't have weight, but they tend to have PCOS.
The skinny PCOS people, they have a different kind of problem.
Okay.
Research is still ongoing to try and figure out exactly. The insulin one, we figured that one out. So we do the test, like I was saying, we do the test, your insulin resistance. We know once we can work on the insulin resistance and make you less resistant, the excess insulin, which stimulates your ovaries to misbehave, will be dealt with. The other people, the skinny PCOS people, they are the ones that give us the most trouble, because resistance to medication, and when they start producing eggs, they produce too many eggs, and then the risk of OHSS and all those complications that come with stimulation comes. So they have a different. We can't use this one's treatment to treat that one, because they are not insulin resistant. We believe their pathway is a little bit different. The enzyme defect is not exactly the same as the one who are insulin resistant, but also has a similar manifestation. So those ones, if you are telling them they don't have weight problems, they are already skinny. They don't. You can't tell them, lose weight and it gets better. It doesn't really. It doesn't really work. So there are different methods you have to try for those kinds of people, unlike the ones who have got weight. But they all manifest. So the end road is the same, but they are coming from different directions.
Okay. All right. So how does PCOS affect ovarian function and fertility? Because I'm asking this because I read a book by Rebecca Fett. It says that it starts with an egg. So in everything, it starts with your egg. And already we are talking about ovarian function and reserve being a problem. So how does that affect your ovarian function?
Quick, we have to go for a break, so I have to try and answer that one quickly. So let's talk about the insulin resistance one. That one, the pathway is better understood. So because of an enzyme defect, glucose levels are higher than they should be. The body produces more insulin to try and push the glucose into the cells. It tries and may succeed to an extent. But that high insulin level starts telling the ovaries to produce more male hormone instead of allowing it to produce smaller male hormone and less female hormone. At the same time, the protein that arrests the male hormone levels are lower. So the male hormone manifestation is higher, and that is why you get the hairy nature and acne and things of that sort. So the people who are working about the pimples they have is actually because of PCOS and not just pimples.
Okay.
So, but by making the ovaries produce more male hormone, One of the other things it does, it also makes the middle of the ovary becomes hypertrophic. It grows excessively. The combination of these factors cause the ovaries to produce hormones in a wrong proportion and in a wrong manner. The end result of which is that the normal process that allows so in a normal cycle, your LH levels are low, the middle of the cycle they rise, and then you ovulate. With the PCOS person, the LH levels are high from the beginning, so there's no low to high to cause the trigger. That trigger process does not occur with them, and the end result is that they don't ovulate. And because they don't ovulate, they tend not to produce progesterone. Because they don't produce progesterone, they tend not to have their periods. And that is how the cycle goes. And then eventually, when they do have their periods, during the months they're not having their periods, the lining is building. The lining becomes very thick. Eventually, when they do have their periods, it's like having 4 periods in one week, or in 10 days, or in 1 month. So you just keep bleeding, because the line that has been built actually started breaking, not in the normal stabilize and remove, but it breaks in pieces because it's too tall. So you can imagine a building that is too tall, it's unstable and breaks. So today here breaks, so you bleed. Tomorrow this other place breaks and you bleed. Another portion breaks. You don't have the normal system where everything is stable and we remove the building on its foundation, which is what happens in a normal menses. Progesterone level drops, the whole building comes out, the whole menses comes out as one level, one layer, and over 5 days it sheds and that's it, it's gone. No, this one, the building is there and it breaks in pieces.
Like a month, somebody can have.
You can bleed for an entire month. Yeah, and that is why it happens that way. So you don't ovulate, you don't get your menses, and the menses can become, when you eventually bleed, can become prolonged, and then we go through the cycle all over again.
All right, so that means if I had a friend who bled throughout, like for a whole month, so such people who bleed, who have heavy and prolonged bleeding, do you suggest that they should look out for problems of PCOS?
Yes, because the people who have long prolonged bleeding, there are mainly 2 major things: PCOS or submucous fibroids. Those problems would cause them to bleed. So the trick is deal with it. So once you have that problem, see your doctor as quickly as possible.
Okay.
So 25 minutes have gone so fast, and my guest has a meeting, so she has to run at 3:45. We shall have our first song, which shall be short. That is a song called "At All Costs" by Dusin Oyekan.
Zed 101.9 FM.
The value of my life is how much of you I carry. The impact of my life is how much of you people see. The value of my life is how much of you I carry.
Zed 101.9 FM.
The impact of my life is how much of you people see. Somebody say, the value. The impact of my life. The value of my life is how much of you. The impact of this life. Somebody express your appetite to him.
Zed 101.9 FM. Zed 101.9 FM.
Welcome back. This is Zed 101.9 FM, and you are listening to the Zed Wellness Link. And today I'm your guest, Dr. Padiaite, being asked questions by Laurentia Massa Oting. She's a clinical psychologist who happens to have PCOS. Our topic for today is PCOS, and we are answering all your questions that have been channeled through here on the subject. Laurentia, next question.
Okay, Doc. So I wanted to find out, usually when we are trying to get pregnant, it's very difficult with PCOS. Can women with PCOS still get pregnant?
Yes.
And if so, what steps can be taken to increase their fertility?
Well, there are several things the doctors can do. That one is doctor talk. But there are several interventions. But before that, we need to optimize you. That's the problem. The tendency is to give medication. There are problems that she has, and she's manifesting those problems. And if you don't investigate fully to know which of the areas her defects are, you would end up trying to force her into getting pregnant when there's a problem that if you fixed, it's a lot easier. So what I've discovered is that try and fix their defects, after which they do get pregnant. The chances are actually better. We try to get them to ovulate. So we try to get them to produce eggs. The challenge with PCOS people is that they don't release their eggs. When you give them medicine, sometimes they give you too many eggs. And that one too is dangerous. So sometimes you can actually tell the patient, you know something, we've given you the medicine, but you have over-responded. So the safest thing to tell you is stop. Don't have sex. Don't try and get pregnant. We beg you. We know you want to get pregnant. We know there are plenty eggs, but you have got too many. If too many of them get fertilized, you end up having too many babies.
Okay.
And your body can overreact to that production. And that can put you in a life-threatening place. So sometimes we tell you, stop, don't. Your body has over-responded. We need to, slow it down a little bit. But there are steps you can also take to ensure that you don't over-respond. So it's actually better to spend time preparing the patient before you start trying to get her pregnant. Once you can get them to ovulate, so first of all, you try and get them to produce more eggs, because what happens is that they tend to have a lot of baby eggs which don't grow to become adults. And it's like your other sister didn't get married, so you can't get married. You two didn't get married, one behind you can't get married, and they're all stuck inside there. What we try and do is give you medication to try and get the bigger ones to, complete their growing process to mature, and then we give you another medication to help you to ovulate. Once you succeeded in getting you to ovulate, then the next thing is you have to have sex at the right time. Caution. I tell my clients, I beg you, don't go and call your husband and say, doctor says you can have sex today. Doesn't work. Kojovi will not get up. That day, Kojovi will be able, because he's busy thinking, yeah, if we do this and she doesn't get pregnant, she'll cry. Then I'll be disappointed here. Then he can't think. And because his mind is occupied with all those things, erections sometimes disappear when the brain is otherwise occupied. So please, don't tell your husband today is the day. Just be extra nice. And do what it takes to get your one shot today and one shot tomorrow. When we say we've given you the injection, go and perform. Don't call your husband at work and say, doctor says today you have to. I beg you, don't do that. Just be extra nice. What time will you come home? I've made your favorite food. Whatever you have to do to get him home and let him do the needful, let him do it today and tomorrow. After that, whatever you want to do, you have collected what you want. But it's really important that you have intercourse at the right time, because assuming we gave you an injection, you have a 36-hour window. Sperm can live for up to 3 to 5 days, for quite a number of people up to 5 days. If you have sex, the sperm must wait for the egg. Don't say they gave me the injection, so I'm waiting for the ovulation time. No, you would miss the boat. Have sex before, preferably more than once, so that there will be enough sperm sitting over there for the egg to take advantage of. Those people tend to have other problems even after they've gotten pregnant. They have difficulty in keeping the pregnancy. They have first 3 months problems, they have second 3 months problems, and sometimes you actually have to keep them in bed. I recently saw somebody who has lost 3 pregnancies because she gets pregnant and then she will lose the pregnancy. It's all related to the PCOS problem. So you have to help them get pregnant, then you have to help them stay pregnant for the first 3 months because they don't produce the right kind of hormones. Then the next 3 months, they lose pregnancy for a totally different reason. That one is difficult. It can be really difficult to fix that part. Sometimes, despite everything you try, the uterus can just not keep the pregnancy. But most of the time, we are able to successfully get them. And a lot of times, you have to make them prisoner. You have patients that you tell them, hey, you have to stay in bed. If you can't trust to stay in bed at home, you stay in bed in the hospital. And that increases their chances of actually getting pregnant. So it's quite a bit of work, but it can be done. And for those who the uterus is always misbehaving, the surrogate option is there. We can give the pregnancy to somebody else to carry for 9 months for you, and then collect your baby afterwards.
Because that led to my follow-up question: that why is it that most of the time people with PCOS miscarry,
Yeah.
lot, and they have higher risk of preeclampsia and all that.
Yes.
So, what causes that?
The miscarriage in the first trimester is different from miscarriage in the second trimester.
Okay.
The first trimester one is hormone related. They tend not to produce a particular hormone. You have to support the pregnancy and give them enough of that hormone. Once you give them enough of that hormone, they can stay pregnant. For some of them, they need that hormone for more than 3 months. And so you need to continue supporting them. But for a different batch of people, when they lose the pregnancy for a different circumstance, it's more inflammatory in the second trimester. So you've got hormonal in the first trimester, inflammatory in the second trimester. And that is why with every patient, if you tell me I had a miscarriage, I say what happened. And I need the details. And sometimes the patient gets a bit annoyed. I said, I want to know exactly what happened. And sometimes it takes a long time before they would understand what you mean by I want to know exactly what happened. Because that exact information tells me whether it's problem A or problem B. And then we know which one we are fighting. Because if you try and solve problem A's problem with problem B's solution, she will still lose the pregnancy.
Okay.
And so there are interventions that you put in place. And if you put those interventions in place, your chance of success are higher. If you don't put those interventions in place, you are screwed. The pregnancy is still going to come out.
Doc, you mentioned inflammation, and it takes me to a question on dieting. During my journey, I was taking my supplement as required. I was taking my medications as required by my doctors, but I was not properly eating well. And it didn't increase my chances in any way. But I noticed a lot of difference when I started eating well. I mean, cutting out the junks and the carbs and all that. So does diet play a role when it comes to PCOS? And how does that improve upon our
Diet
fertility?
plays a critical role, especially for the insulin-resistant people. So let's try and understand this. The patient or the client has got an enzyme defect. Because of that enzyme defect, it's not able to push sugar into the liver. Okay, I'm giving you a scenario. So when the sugar enters the blood, the sugar levels, high sugar levels causes you to produce high insulin levels. High insulin levels is to try and push the sugar out of the blood and prevent you from using fat. Somebody says insulin's main job is to prevent you from using fat. That is why they gain weight. So what happens? If your sugar cannot go into glycogen and you are not burning the sugar will go into fat. And the fat worsens the PCOS, the whole cycle all over again. So it just makes everything worse. If, however, you reduce the amount of sugar you put in your body, and by sugar, I mean sodas, juices, processed food, flour, rice, those things. Those are things that convert to sugar very quickly. If you take those things, your sugar level rises very high, and so the insulin level will rise very high. What if you took the sugar out? Or you took very, very low amounts? Very, very low amounts. Then the insulin would not rise like that. Meanwhile, it's the high insulin that is triggering your ovaries to produce abnormal hormones, abnormal hormone ratios. Remember, high sugar causes high insulin. High insulin causes high abnormal hormones in the ovary, produced by the ovary. High abnormal ovaries causes you not to ovulate, and this process just goes on and on and on. So what if we reduce the sugar level? The insulin level will come down. The effect of the insulin on the ovary will also come down. And so the ovaries will start behaving better. So just by changing your diet, just that part, automatically means that the amount of work we have to do to get you pregnant reduces significantly. The amount of medication we have to give to you reduces significantly. So diet plays a critical role. The more processed food you eat, the more in trouble you are. The more carbohydrates you eat, the more in trouble you are. You understand? The more easily digestible food that you eat, the more in trouble you are. But if you eat meals that are more complex, even if it's carbohydrate, more complex carbohydrates, if you're eating your significant vegetable load, that will ensure that the sugar now enters your blood very slowly because the vegetables have occupied part of the space inside your tummy. If you're eating a lot of meat, that makes you full. If you're eating avocado, which is a healthy fat, that also makes you full but slows down the absorption of the sugar. Then the sugar levels are lower. And if they are lower, it means insulin will be, the response of insulin will be lower. And that lower response would result in lower hormones. There are people who eat 1 meal a day because of this condition. There are people who have actually gone off carbohydrates totally. But the body can make the carbohydrates it needs from its natural processes. And as a result of that, insulin levels drop. And for those who are diabetic, there are some people who have stopped eating carbs and their diabetes is gone. Purely because, hey, if you can't handle the sugar and you take away the sugar, then there's no diabetes. There's no excess sugar in the blood.
That's true.
So people have actually managed their PCOS themselves with a little bit of help, purely by being strict with their diet and ensuring that they don't eat the kind of food that their body can't tolerate, and they start ovulating properly.
Okay. So, Doc, when it comes to issues of irregular menses, I remember some time ago they gave me birth control pills.
Yes.
And I had to throw it away.
Why?
Because I thought, why I really
I'm trying
want to
get
get
pregnant.
pregnant and you're giving me birth control pills. I want us to understand how effective is birth control in trying to regulate menses and acne with people with PCOS.
The birth control pill is given in PCOS not because we don't want you to get pregnant. Some people give it because it allows you to have a regular menses. It doesn't solve the problem, but it allows you to have a regular menses. So if you have a young girl, 16, like when you're in school, you're in SS, your periods are misbehaving, it's sometimes easier to say, put her on the pill, she'll have a regular menses, and it will allow us to, we will deal with it when she comes on vacation or when she finishes school. But for now, let her, focus on her education and have a regular menses, and we can work on this later on. But one of the advantages for somebody who's trying to get pregnant is for a different purpose. The excess eggs have all grown up and they are, teenagers walking about there competing for space. The pill cuts off food supply and so causes them all to come down. So when we start stimulating you, instead of 20 people fighting for space to go through one door, we have maybe 5 people who want to go, who will now respond. And that 5 people is what we can manage and what we can deal with. Because the 5 people that will share the medication that we are given, unlike the 25 that we had before. So the pill allows you to try and synchronize the eggs, the follicles. It allows you to bring down the excess, your excess hormones, and allows us now to be in a better position when we actually give you medication to try and get you to ovulate, that your over response would come down and you have a slightly less aggressive response. So yes, it's important, and you shouldn't have thrown it away. But of course, if you didn't get the explanation, you don't understand why it is being given to you in that manner. So a good observation.
And through you, I understand now. And
Okay.
Thank you very much. So how does PCOS affect long-term health, such as risk for diabetes, heart disease, and other conditions?
It's one of the major contributing factors to those things. If somebody has PCOS today, in 40 years, it is very likely to be diabetic. Because think about it, and we are talking especially about the insulin-resistant type. Think about it. Because you are not able to metabolize your sugar well, your sugar levels in your blood remain high. Your insulin level goes very high to try and control that sugar. Whenever we test your sugar, it is normal. It is normal because the insulin is overworking. Now, can you imagine driving your car every time and your ref counter is in the red? What will happen to your engine? At some point in time, the engine will get destroyed. So assuming you were born and you have 10 gallons of insulin, that's supposed to last you 100 years. And the factory that produces the insulin can produce 10 gallons for the 100 years. But because of your PCOS, your sugar levels require that instead of using, let's say, 10 mils of insulin per month for life, you now use 100 mils of insulin per month. The end result is that your 10 gallons will finish before you're 100. It will finish when you are like maybe 50 or 60. So by the time it finishes at that point, you can no longer control your sugar levels. Because it was the high insulin that was keeping the sugar levels down. That made, when you go to the lab, they tell you, oh, your sugar is normal, and you're happy. When in actual fact, your engine is overheating in an attempt to control the sugar levels. By the time you get to 50 or 60, the pancreas can no longer produce the sugar. What happens? The pancreas gives up. It can never produce the insulin. The pancreas gives up. The insulin level drops. The sugar level can no longer be controlled because of the insulin level is now low. We now check your sugar levels and we say your sugar levels are high. And then what happens? We now say you're diabetic. High sugar level in the blood causes inflammation. The inflammation eventually results in atherosclerosis. The atherosclerosis will result in narrowing of the blood vessels. The narrowing of the blood vessels will result in what you call cardiovascular disease, hypertension, heart problems, strokes, blah, 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 blah. All this started. Meanwhile, we've had a warning sign since you were 21 that this woman in 50 years will have this problem. If we fix it now, we can avoid it then. If we don't fix it now. So PCOS is a problem that if you have it, you must be on treatment now, even if you don't intend to have children, because that is what is going to protect you several years down the line. I wish there was a way we could detect, apart from, of course, we can measure insulin in men too, because it's like you guys have women have an out. The moment we say, we can protect you for the rest of your life. What about men? We should be also be testing our insulin levels. When you see it is high, they know that you are insulin resistant, start taking
I think
medication.
That's one thing I want you to reiterate again for people to hear, because I have other colleagues who have PCOS and think that it is all about your sugar. So that was what I knew before I met you like 3 months ago. Remember I asked you, you said my sugar is fine, then why is my insulin high? Because whenever they tell me that my sugars are fine, I know that's okay. Then I don't have insulin resistant kind of PCOS. So I think a lot of people are confused, especially when they are saying that you have PCOS and it is insulin resistant. They check your sugars, they said you are fine. A friend of mine called me, they said I have PCOS, but my sugars are fine. So one thing is, most doctors don't do the insulin test.
That is true.
And that is the first test that you did for me. I have never done that. So I've always thought that, my sugars are fine. I don't think I have PCOS. So I think you should make it clear for people to really understand, especially people with PCOS. They think that if you check your sugars and they are fine, then you don't have any problem with the insulin type of, but you don't actually do. But why don't they do it for us? I think it's something that has to be done.
Well, it's we have the machine. I mean, from day one, we'll get the machine. So we run our own insulin tests. A lot of the big labs, you get the result in like 2 weeks. I can get the result if I want in a day or two. But it is it's for me, it's very critical. It's one of the first things I test. FSH-LH ratio, insulin. FSH-LH ratio, insulin. I expect your sugar to be normal unless it is. If your sugar is abnormal, your system has collapsed. If you are pretty young, it's unlikely to have collapsed. But your sugar is normal because you are overcompensating. And the insulin test tells us if you are overcompensating. And then we know that, hey, fix this woman before she burns out. Because she will burn out. At the rate at which this is going, she will burn out. So I think it's really important that you've asked a very good question, and we need to do more insulin testing. Not necessarily just testing sugar and thinking you're okay. No, until you know your insulin level, you are not okay.
Okay.
You are not okay.
All right. So you've talked about insulin form of PCOS. Do we have other forms of PCOS aside
Yes,
the insulin?
there are other ones that the insulin levels are normal. So we know that there's a defect in a different area, but not necessarily in the insulin metabolism. And there are other things that have been suggested, still being investigated, because we are still trying to understand disease. We understand the insulin pathway, at least I do. It's quite clear what is happening, and the interventions we put in place to deal with it. We have an enzyme defect in the insulin pathway, and because of that, you don't produce a particular chemical. That chemical holds the key that opens a door, and that door allows you to store the glucose in other areas. Because you can't open that door, your glucose accumulates, and then your insulin goes up. One of the solutions is to give them the key that opens the door. Once you give them the key, the sugar goes out, the body starts behaving itself. So those are just one of the solutions. There are multiple solutions that we can try and do that. For the non-insulin resistance, we are still trying to figure out, so which problem is your own? There have been suggestions, this or that, and we are still looking at it, but hopefully we'll be able to figure that out very soon.
Okay. So my final 2 questions is that are women with PCOS at higher risks of developing endometrial cancer?
Yes. And that is because they don't have their menses regularly. And it's what you call uncontrolled estrogen. The estrogen comes. Normal person, you get estrogen for 2 weeks, you get progesterone for 1 week, then the progesterone drops and you get your menses. With the PCOS woman, she's got estrogen for like 3 months continuously with no break. Endometrial cancer feeds off estrogen. That's high levels of estrogen eventually causes, or continuous levels of estrogen causes the one cell to misbehave and lose control, and then it starts multiplying, and then it gets endometrial cancer. So yes, they are at a higher risk.
So with all that you are saying, how often should a woman with PCOS go for checkups? Not necessarily because of infertility, but if you have PCOS, how often should you go for checkups and screening to monitor the long-term health risk of it?
Normally, would say that the minimum is once a year.
Okay.
However, this is not a case of going for checkup. This is a case of you must be on an effective management program. Because if you're on an effective management program, you'll be having regular visits, so we can be managing your uterine lining to see if it's okay. But we are dealing with the cause. So rather than sitting down and waiting for the cancer to come and then we try and manage it, let's prevent it from coming. If you get your menses to be coming regularly, you understand, you will not need that anti-cancer, that whole cancer intervention, because we are preventing it from day one. It's like cervical cancer. Test for HPV, then there's no need for later on be doing all kinds of things. You catch it early, you monitor it early, you deal with the disease very early. It's the same thing with this one. We know that if you have diabetes, if you have got PCOS, you have got a higher risk of getting endometrial cancer. So what do? Deal with that problem. Keep the insulin levels down, keep the estrogen levels down. The end result is that you'll be at a lower risk. Problem is dealt with.
So what I can understand is that it's something that you should manage for the
for
rest of your life.
Yeah.
Because it's a chronic.
It's not headache that you take medicine and it goes. It's not malaria that you take malaria medicine and it goes. No, it's a lifelong condition. Manage it and you'll be fine.
Okay.
You'll be fine. Don't manage it and then there'll be issues.
All right. Thank you very much, Doc, for answering all the questions.
I'm very grateful to you for coming.
Okay.
We shall move to our second song. Today, this is a little bit different. Our second song is called Big God by Kofi Osu-Pepra.
Zed 101.9 FM.
Who's more big, bigger, biggest? Tell him he's big. Who's more big, bigger, biggest?
FM.
Who's more big, bigger, biggest? Tell him he's big. Who's more big, bigger, biggest?